each of the practices that's been invited to speak, we're hoping for just a 3 to 5 minute summary of your experience so that we can learn from it.
So yeah, I was going to welcome that and introduce each of the panel members, or just say their names too up front so people know who they are, or go wait till we go to the panel.
So they'll each, well, I think Jennifer will lead. She's got some data that we were able to gather.
I was going to have her start off after I did what I put together was a welcome to the audience, and then the goal, then a special thanks to Tappy, and then an overview, which will open with Jennifer's program, followed by Damien's presentation, and then Gretchen's presentation. And then following that, our select panel will share their experiential knowledge.
Yep.
And to thank the presenters and panelists. And then I was going to name off each of the panelists and where they're located.
That sounds wonderful.
Okay.
All righty. So we've got
the only quick thing I might say is I think I have Dr. Hull going before Damien.
Okay, I can reverse that. Okay.
Oh, that's true. The slides.
So if that's the case, then I will just my own experience from my practice. I'll wait until you do the I don't know if I'm one of the panelists or how that's going to work. When present, kind of, because that's two different things I was going to do. One was the presentation of the survey, and then the discussion of what my experience has been out in the field.
Okay, Jen, is there a chance to make a quick change on the slide, or we just make the?
I just thought that would fit better in when, like, after the discussion of the survey, so not as part of the survey.
That's right, and I wasn't clear that you were doing both. So.
Oh, I'm sorry. Yeah, just since I'm in general practice, I thought I mean, I definitely have comments to make about the challenges that we have faced. I'm in general practice, but I'm also part of a larger organization, all private practice though.
Okay, very good. So
I'll just put that Gretchen will also serve as a panelist.
That's right.
Right, lead into the panel. Okay.
Yeah. And then I think the other important comment is that we're really not going to encourage discussion beyond those summary presentations, but we'll encourage comments in the chat box so that we can get feedback.
Yeah, and then I was going to mention that after I said the goals, to explain that this is a listening session. There will be no discussions, but we will invite you to make comments in the comment box, and the Tappy staff will record them.
Perfect. You've got it.
Okay.
Hey, Debbie.
Hey, hi, Damien. Thanks for jumping on.
Yeah, of course. Happy to be here.
Yeah, we're glad you're here. And we just walked through a little bit of the outline, and I think you're third up.
Okay, sounds good.
Okay. And Blanca is muting herself. She lives close to a train track. And it's not going to let us hear the train go by.
Yeah, I guess you could say I live on the other side of the track. Just kidding.
I got it.
Debbie, I just got a message from Dr. Acevedo-McGarble that she's seeing one last patient and she'll be able to jump on.
Yeah, she let us know she was coming on a little bit late, and that's fine. As long as we know she's coming. Okay, do we know who iPad 5 is?
I don't believe so.
Okay. Very good. Well, good evening, everybody. It's 6 p.m. and we welcome you to TAPI's hosting of a COVID vaccine listening session. And welcome to Dr. Douglas Richardson, who's going to facilitate the conversation or the presentations this evening. So at 6 o'clock, we are going to try to get this done in 1 hour. And so with that, Dr. Richardson, I'll turn it over to you.
Thank you very much. Good evening, everyone. I'm Douglas Richardson. I'm a retired primary care pediatrician and a former president of the Arizona chapter of the American Academy of Pediatrics. To our audience, thank you all for logging in for this listening session, and I welcome you to what will be a stimulating and enlightening evening of presentations regarding COVID-19 vaccination and the pitfalls, challenges, and solutions that a variety of community practitioners and stakeholders have experienced and worked through. Tonight's goal is to provide information to enhance identification of and reduction of barriers to COVID-19 immunization and to engage the medical practices throughout Arizona to increase access to COVID-19 vaccines and equitable vaccine distribution. Since this is a listening session, there will be no discussions, but we invite you to make comments in the comment box. The TAPI staff will record them. Special thanks go to TAPI, the Arizona Partnership for Immunizations, who has spearheaded this event. For 28 years, TAPI has supported, fostered, and engaged in proper immunization education, access, and delivery. The timing of this event is apropos as our state, our nation, and all of the nations of the world work to bring an end to the devastation and hardship this pandemic has caused and work toward a return to normalcy. An integral and paramount component of that work is COVID-19 vaccination. We will open this evening with a CDC Data Overview by Jennifer Tinney, TAPI's lead on programs and training, followed by a presentation by Dr. Gretchen Hall, a pediatrician in Tucson and immediate past president of the Arizona chapter of the American Academy of Pediatrics. She will present the Arizona chapter's COVID-19 survey And then Damian Johnson, the Arizona Medical Association's Communications Director, will cover the Arizona Medical Association's COVID-19 Physician Survey. Following that, our select panel will share their COVID-19 experiential knowledge. I give a great big thank you to the presenters and the panelists for being willing to give of their time and share their knowledge and experiences. Our panel will include Dr. Hall, as we have already mentioned, Dr. Tara Lefkowitz, an urgent care pediatrician with Phoenix Children's Hospital, Dr. Sandhya Ravi, a primary care pediatrician in Peoria, Dr. Sarah Wiersma, a primary care pediatrician in North Scottsdale, Dr. Richard Dobruzin, a primary care family practice physician in Deer Valley, Dr. Karen Acevedo Mogarbal is a primary care family practice physician in East Mesa, Dr. Stacy Kagi, a primary care family physician also in East Mesa, Dr. Vera Meyer Bennett, a primary care pediatrician in Lakeside, Arizona. And also we have Patty Gast, with the Master's in Public Health, who is TAPI's Billing Program Director. Ms. Tinney, if you could start us off.
Absolutely. Thank you, everyone. Tonight, I was just going to go over a little bit of the CDC data, survey data, so we know a little bit of where our starting point is as we begin to move COVID-19 from these pop-up clinics into the medical home. Do you want to go to the next slide? And it's, it's vital now that we get COVID into the medical home. It needs to be in those everyday conversations and for every well visit and sick visit as patients go in. We know that we've been missing quite a few vaccines, routine vaccines for both children and adults. For the VFC program, the dose count orders have been down by almost up to 12 million last year. So we know we've got a lot of adolescents and kids who have missed vaccines since the pandemic began. And then a new study just came out that says 17 million adults have we've missed adult doses during that time as well. So we've got a lot of catch up to do, which is why it's critical that we get COVID vaccine into the medical home, into the provider offices. And with the new co-administration, meaning you could give a COVID vaccine with a pneumococcal or a flu or a Tdap, this is the time that we begin to integrate it into the typical routine schedule that we see. Open networks are across the state and across the country, meaning you can give a vaccine to a patient that is not typically on your panel and bill for that vaccine and be reimbursed for it. And that means you can vaccinate the whole family as they come in. So as we begin to move into adolescence for COVID vaccine, this is a great opportunity to catch up mom, dad, grandparents, caregivers who bring the kids in to those visits and any other family members. If you want to move to the next slide. We have a lot of people now, this is some of the adult data looking at how patients feel about COVID-19 vaccine. And we have quite a few people who have still not received it, as you all know. We have some, quite a few that have, and then we have some that are never going to get it. But in between is that kind of key target group that you all can make such a big difference in. That's the people who say in the surveys that they'll get it as soon as possible, but they may have barriers in transportation and access to care and can't get to one of the big clinics. So this is where you need to make sure that we can get them vaccinated when they go into the regular doctor's offices. We have a group of patients that are wait and see. They're still waiting to get the data. They need a little bit more one-on-one conversation, again, with their trusted providers. We have some that say that they'll only get it if it's required, meaning they're not an absolute no, but they still haven't decided that this is what they want to do. So this is where those continued conversations over and over in every office visit is going to make the difference. Next slide. We're going to begin to move into patients younger and younger. Right now, we're down to age 12 and up. and fairly soon we'll begin to move into kids 2+. So these are a lot of families and a lot of people who are still wondering whether or not the vaccine is something that's right for them, for their family, for their children, and especially down to those younger ages. So this is, again, another critical opportunity to establish that safety and through a trusted relationship in your offices. Interestingly, fathers were more willing to get a COVID vaccine for their children than mothers were, and older mothers are more willing than younger mothers. So younger mothers are also that group that are maybe hesitant about getting their vaccine, or they're still waiting to see if they're going to get it. So that kind of, younger adult group is still kind of the ones that are hanging on and not necessarily moving forward to get a vaccine next. Next slide. Some of the common safety concerns that we're hearing are increasing faster in women. So as we've had this vaccine for longer, they're actually becoming more concerned about the safety of the vaccine. So some of the things that they've responded with is they're not sure it will be safe, that it was developed too quickly, they don't really trust the published information, and they don't have enough information to make that decision. And that's where you all are critical in getting to any point where we have enough people covered that we can reach some sort of herd immunity for COVID-19. Next slide. This is my favorite, and this was asked primarily of parents with adolescents and young adults still at home, where they felt most comfortable taking their kids to get a vaccine. And this applies also to those patients that are adults but are still hesitant to get their own vaccine. And those trusted sites do include some of the drive-in clinics, the pop-up clinics that we have, the community offices that have allowed patients to walk in and get a vaccine, pharmacists, but the number one place that people want to get a vaccine is in their trusted regular provider and their regular office with their doctor making the decision with them. And that's 74% of parents and hesitant patients really want to get a COVID vaccine in their provider office when they go in for other visits. So it's a testament to how much they, really trust the relationship and the decision making that happens between the patient and their doctor. So with that, that's the end of mine. Unless if anybody has any specific questions, I'm happy to take those in the chat as we go through. But it was really some interesting survey data that's beginning to come out about how people are feeling about getting a COVID-19 vaccine.
Okay, thank you very much, Jennifer. Dr. Hull, if you're ready to go with your slides, go ahead.
I think that they should be in the slide set too, right? Okay, so again, I'm Gretchen Hull, the immediate past president of the Arizona chapter, the AAP. And this is survey data that was taken in the end of April, early May. Next slide. Yeah, all the information pretty much is on the slide. There are 59 people actually participated. And I'll just go on to the next slide. So this is like, to what extent do you need support in addressing the following COVID-19 topics during patient counseling? And in some interesting findings, 87.5% of providers need more information regarding COVID-19 vaccine effectiveness. And then 91% of providers report needing more information regarding COVID-19 vaccine safety. Next slide. This was, to what extent do you need support in addressing the following aspects of practice implementation of the COVID vaccine? And of interest, despite continued messaging, 57% are still unsure about how to enroll as an Arizona provider in the COVID-19 vaccination program. And 70% of providers need more information on COVID-19 vaccine storage and handling requirements. 73% of providers still need information regarding payment. That's a big concern. And yeah. Next slide. I know it's a lot of information, but What are your top concerns for administering the vaccine to your patients? So, I mean, you can see here, but I mean, it's important that we work together to inform the providers about the latest guidance. This was done before we knew that we could co-administer or give closer the vaccine with other vaccines. So that's important. Really important to increase messaging regarding the new guidelines and the change in storage requirements. Many were worried about rolling out and how to practices will actually receive the vaccine supply. And so there's really a lot of need for increased communication about what is involved in actually participating in the program. The next slide, just some quotes from some of the participants. So there needs that. I think one of the most challenging, if you can read these, is knowing how to store and the quantity that they have to order and how they would be able to store those in addition to the vaccines they already have. And I mean, just using it and before it expires and not having wastage. Next slide. I mean, I think most doctors want to be able to vaccinate, but it's a little daunting. It feels that way. Next slide. And if you have any other information, please feel free to contact the chapter, and you can ask any questions in the chat as well.
Thank you, Gretchen. Mr. Johnson, Damian Johnson from the Arizona Medical Association. Let's hear about your survey.
Yes, thank you. So I do not have any slides, so mine's just going to be a verbal presentation to all of you. So ARMA put together a survey and targeted private practice physicians, specifically in primary care physicians within our membership, as well as had the survey disseminated through Pima County's listserv, and then we're working on, so the survey is still open and working on disseminating through Maricopa County Department of Public Health's listserv as well. So total to participants so far have been 42 physicians. So I'm going to start off with the initial numbers from the survey, and then I'll finish off with some noteworthy comments that were provided by the physicians that participated. So of the total participants, 71% stated they were successfully registered with ADHS to administer the COVID-19 vaccine. Of those registered to administer, 19% had ordered COVID vaccines directly through ACES. 72% claim they have not ordered through ACES, and then 9% were unsure. Of those who ordered through ACES, 50% stated they will continue ordering through this process, with the 17% that were unsure. Of those who have not gone through the vaccine onboarding process, the following was indicated as the reason for delay. 14% stated they needed more information on the process. 29% said vaccine reporting requirements were too onerous. 43% do not have storage capacity for the vaccine. 71% were concerned that they do not have enough patients interested to be able to administer all of the ordered doses. When these physicians were asked if they plan to order COVID vaccine for the practice in the future, 46% stated yes, while 24% stated that they were unsure. When they were asked to indicate why they have not yet taken advantage of the opportunity to order, 19% said they just have not had time. 6% stated that they were in the process of implementing office protocols for vaccine administration. 25% stated that there were too many barriers to the process, and 50% stated there was low patient interest. And then the final stat that I have for you is when they were asked to indicate what they deemed to be the biggest barrier for vaccine administration, 18% stated reporting requirements were too heavy. 18% stated low patient interest, and then 62% stated other. And some of those other were some of the noteworthy comments to those questions that I just listed above with the data. When asked if they had encountered any challenges in the ordering process, some of the comments included unable to order more than 200 doses. Some stated internal challenges within their practice, and others stated the demand for the vaccine had dropped by the time they were able to order the vaccine for their practice. When asked if they will continue to order the vaccine through the ACES process, some of the comments included they had no intentions or plans for any further clinics within their practice for vaccine distribution, and the minimum order requirements were too high and that the demand does not meet the current requirements. When the physicians were asked if they had any further feedback to share on vaccine onboarding and administration experience, some of the feedback included that ability again to order more than 200 doses per week, and the vial size is hard to avoid vaccine waste. Unsure if they will continue ordering due to the vial size. When asked if they plan to order the COVID vaccine for their practice in the future, some of the comments mentioned not having the capacity. Multi-dose vials present issues that are difficult to manage in a practice setting. Would be better off if they were all offered in single dose or pre-filled syringes. Unsure if the need for their patient population, given the other avenues that are available to obtain the vaccination, and workflows to ensure they do not waste significant dosage. And then finally, when they were asked if there is any other feedback that they would like to give, several stated that the instructions for ordering were very clear. And if when they did order or if they would need to order, they believe it would not be an issue. Several wish there was more of a single dose option. And then a few stated as well there was difficulty with within their workflow of their EHR systems. So that's a recap of our survey. Thank you for your time.
All right, thank you very much. Next, we will go ahead then and have our panelists give us some feedback and exposure to their personal experiences. We will lead off with Dr. Gretchen Hall from Tucson. Hall, I don't know if I say that so that you can understand it's Hull.
It's hull like the hull of a ship. No. Anyway, so I practice in I'm in a small group myself there are 4 of us physicians, but I'm also part of an ACO, Arizona Community Physicians, which has well over 100 physicians and providers. It's a large organization here in Tucson. And it's been a challenge for us because when we had onboarded to be able to provide it, which was easy for the pediatricians relatively because of BFC already being involved, but actually starting to give it the ACO bureaucracy has made it an incredible challenge. They are very concerned about billing, about how to work with it with our EHR. We have Epic, which is still new to us. So the challenge of figuring out how to, just all of that is very hard. It's been difficult to get assurance that there's no counting of wastage. And I think it was mentioned in that previous survey that one of the barriers is that people don't like the idea of the large vial size and not being able to use up all the doses. And giving parents and family members, how hard is that? How much time is it going to take to then sign them into our EHR to be able to do it? Or how do we do that? We're very concerned about all the logistics of giving it to people who are not our patients, although I really want to be able to provide it because I know just having conversations with parents that if it were here, many of them would get it who would not otherwise go and get it. Just clarification, we really need clarification of billing private versus Medicaid, Medicare versus direct to the government. Like what about our undocumented parents and how to make them feel comfortable getting it? I mean, there are so many levels of that. Just streamlining that would really be helpful. The shipment size, if they're ordering 1,000 doses is really not logical for us. We can't use all of that up in the time that we can store it in our refrigerators and freezers and again, using those up. The adult providers in ACP have pretty much categorically said they are not at this point interested in providing the vaccine, that it's easy enough for their patients to get it elsewhere. And so why go through all of this hassle? I think it's mostly the pediatricians in ACP who really want to be able to do this. And if we have success in doing it, then that would be great. I do know there's one practice that has started doing it within ACP, Keith DeVern's practice, Clara Vista, they're in ACP also. And they just started yesterday, but they did have to waste a couple doses. It's almost painful to have to do that. And we are, with our experience with VFC, that just scares us a little bit. And so again, assurance along those lines. There are more challenges, I think, than most people realize. So anyway, that's my experience.
Okay, thank you very much. Dr. Lefkowitz, you're next on our list. If you can give us some of your experiences with this issue.
Okay, I did not know that I was going to be presenting, but I'm happy to just give a little feedback of what our experience in our office was. We're a small group, so I have 3 partners and we have 1 nurse practitioner. And what we decided to do was try to devote our nurse practitioner to giving the vaccine. So we had one of our front office people working for a few days, just calling patients and trying to schedule the 10 that we would need in order to use up an entire vial. And that took several hours. And then we had the days that we had blocked her off to administer the vaccine. And then after we were able to give the vaccine, we started billing for the vaccine. And then what happened is we were getting denials all over the place, and for reasons that are really not legitimate and were unfair. And it just ended up being so cost ineffective that my partners were gun shy when we were offered the opportunity to get Pfizer vaccine, even as few as 100 doses, which is what we were given with the Moderna. They just didn't want anything to do with it. And I could not convince them that it would be better this time around. And so it's unfortunate that I'm having to spend several minutes at every visit talking to my patients about why they should get the COVID vaccine, but I can't give it to you. You have to go somewhere else.
Are there any additional supports that you might be able to access to work with your partners?
I mean, I don't know. I have not spoken with our biller in the last week or 2 about whatever happened with those claims, but it's just so cumbersome for our tiny group to dedicate so much manpower to trying to recoup the $40 for the vaccine that we are supposedly entitled to. And it's just so frustrating that we're having to do this. I mean, the companies, when we bill them and they deny the claim, they just say, oh, we'll resubmit the claim. But that's manpower, that's time consuming, and it ends up being not cost effective, unfortunately.
Okay, very good. Thank you very much. Dr. Ravi, would you go ahead and share your experience?
I'm muted. Hi, good evening, everyone. So I'm Sandhya Ravi with Pleasant Pediatrics, and we have, we're primarily based in West Valley. We have 5 locations here, but we have 1 location in Awatuki. We started giving Moderna vaccine in last week of January, and we gave about 45,000 doses of Moderna vaccine, and then we received Pfizer right before it got approved for 12 to 15-year-olds and or 12 years and above, and we've given 5,000 doses so far. So I agree with everyone, especially when you give on a smaller scale. Storage and buying that other capacity, that fridge and all, it's very expensive. We did buy that ultra freezer, so that we can store for all locations at one place. So that was a huge investment. However, some of the challenges that we are encountering are, one of the main ones, it's vaccine finder daily reporting of inventory. When the status of the stock didn't change for 2 months, yet we need to report it every day. Otherwise, we're getting these threatening emails from the regulatory side that they will take our privileges away. It's ridiculous. Every single day that we have to report that inventory for 6 locations, whereas there's no demand right now. Nothing is changing in the stocks, and we're so busy with our clinic too, and we're doing this to help the community, yet so much manpower has to be put onto this, so that's one. And then the next one is billing Medicare is such a challenge. Many patients, many individuals, they don't know their Medicare number. And when we call them, they're actually giving their United Healthcare Advantage plan, but we have to only, bill Medicare. And when we call them for their Medicare number, they're hanging up on us, or they are being very rude to us, and they say that I'm not giving you my number. And so all of these will be unpaid. But COVID only claims we can only submit it to Medicare straight. We cannot submit to other. So the other insurance says we won't pay. And the patient says, I'm not going to give you a Medicare number. Yeah, and some of them don't even know the Medicare number. So, and then this is so interesting. Some of the insurances, especially if we are out of network, they're sending payments to patients directly, and patients are cashing in that check, and we're getting nothing. I mean, so like all of this effort that we put, and we can't to bill the patient, and we don't know how to get this payment because insurance says I paid the patient, but we can't bill the patient. So we have so many claims, unpaid that way. There was one other, oh yes, United Healthcare, for example. So sorry, I'm not supposed to say like insurance names, but they still haven't loaded the new payment as of yet. It's $40. They still are paying that old payment. And even for that old payment, because we are not getting 100% of Medicare, we still are somewhere way below 100%. So they're paying below $16 which is that one payment that was before March 16th. We're still getting that payment. So for all this effort, imagine, we opened the clinics on weekends, we paid our staff overtime, we paid some people bonuses so that we can help the community. And now it's like billing is, all of these issues are happening, And I mean, although we are proud and we are happy that we were able to get so many people vaccinated. And at this point, I will say though, whoever among kids, wanted to get vaccinated, or even among adults, whoever wanted to get vaccinated, they all got it. But it's going to be a challenge, convincing more and more, more people to get vaccinated, especially with the new, finding of myocarditis among young adults or young men or older teenage boys.
Okay, thank you very much. Dr. Wiersma, can you go ahead and share your experience?
I work at a large private group, pediatric practice, and so we had registered to be vaccinated first, kind of as soon as we were able to sign up, but we haven't actually ordered any doses. We were about to order some when they allowed it down to 12, and so we had placed an order. We had actually scheduled some clinics, and we had got no patients signing up because by the time we were going to get our order, everyone who wanted it had already, gone to the state sites, had gone to, other places that hit pharmacies. And so at this point, we've decided we're going to hold off until it's approved down to age 2, just because we're thinking less likely people are going to want to go to the pharmacies. But we were having a lot of issues, mostly like we'd already heard about, with not knowing how much to order, was kind of our biggest concern. And so, if the demand is waxing and waning, we don't want to encourage doses, and so that's been the biggest problem. And so sometimes, like when I'm talking to patients, I mean that they want to get it, but now there's been a lot more hesitancy with different, potential side effects. And so also as a provider, wanting to kind of know, the safety and be able to actually be able to recommend that for teenagers and know more about with myocarditis.
Okay, thank you very much. Dr. DeBrusen, you're up on the line.
Hello, my name is Rich Dauberson. I'm currently a supervising physician director with Cigna Medical Group. My practice is at 38th Street in Bell, and I'm the past president of Arizona Osteopathic Medical Association. I just finished my term up in April. I just want to give a shout out to Dr. Dacha Dorville, who's on the line. For those of you who don't know Dr. Dorville, she's an internal medicine pediatrician practicing in northeastern Arizona on the Navajo Nation. And she has put more hours into the treatment of COVID patients, both inpatient and outpatient, than anyone I know. She won the President's Award from our association for that, and her dedication has been incredible. I don't think she's left Northern Arizona in a year and a half. So our practice at Cigna Medical Group has done quite a few immunizations, tens of thousands of immunizations. We've had drive-through clinics at CJ Harris Medical Center, as well as many of our bigger clinics that we can do drive-through on. And we also ran the Westworld pod, which also did thousands and thousands of immunizations. And we've mostly dealt with Moderna vaccine. We did give out, I think, around 600 or 800 doses in my office that I run. And we did run into some issues that I'd like to talk about. For one thing, they come in 10 dose vials. So the scheduling of 10 people that are going to show up and get these doses is a nightmare. Making sure that all 10 are going to be used, because you don't want to have people show up and not get vaccinated, and you don't want to have a lack of vaccine for people who do show up. And that's been a serious logistical challenge, as well as the 2-dose regimen. And people have to be scheduled for their second dose. And what if they don't come for the second dose? So there's a lot of scheduling trouble with that. We've also noticed with the Moderna, a lot of variability in the amount of vaccines we're getting per vial. And we kind of got it down to a science, but we were getting as few as 8 and as many as 12. And one thing we've experimented with is needle size, and we got rid of 1.5-inch needles because we realized in that extra 1/2 inch of needle over 9 doses, we were losing a dose. And we would get to the end. So we went to 1-inch needles. I think we went to 23 gauge 1-inch needles, and we were getting more than 10. So we fooled around with that. And we were more successful with that. We've also run into some challenges with patients coming into the office who have been immunized by sites that are not entering their information into ACES. And we have seen many people who've come in with their vaccine cards, and they said, yeah, I got my shot, but it's not in ACES. And to me, the biggest offender is the VA. We have run into many, many veterans who have received their immunizations at the VA who show me their cards, and it's not in ACES, and we're manually entering, but I'm not quite sure why the VA isn't entering their information into ACES like everyone else, because it's super helpful when they do. So I guess to me, the elephant in the room, the logistical problem that we're all having in clinics like mine is the 10-dose vial. Scheduling 10 people to come in and having 10 people get the shots is really difficult, and we don't want to waste doses, and yet we really want to effectively not have anybody show up and not get a dose. If these were single dose vials like every other shot we give out, we would have a spontaneity of being able to say to somebody, guess what? We can give you your shot today. All you need to do is sit in this exam room another couple of minutes and we will bring it to you right now, as opposed to we need to schedule 10 people, or now we're down to a point where we give them a handout with the website and the 800 number, and you ought to go to Westworld. And we all know that's a significant downgrade and much less likely to happen. So to me, having spent I think, 8 years in vaccine research in my office in Mesa, involving multiple vaccines. To me, the single dose vial is much better, and the single dose preloaded syringe is better than that. And that's the way all the other shots are coming. Our flu shots are coming in a preloaded syringe. And to me, that is the biggest problem we're having, along with running into a certain group of people who will never be vaccinated for many reasons, including Bill Gates putting a chip in them, the vaccine being made from dead fetuses, to Dr. Fauci conspiratory theories, to government mistrust and things like that. And there's a group of people who will never be vaccinated. I saw a guy today who's about to go in for mitral valve replacement surgery who's not been vaccinated, and he's in his 80s, and he's entering into a hospital, without being vaccinated. He's going to get a COVID test before his operation, but I'm a little afraid of the chance of him catching the COVID virus in the hospital after a valve surgery. So those are some of the thoughts that I came up with, and I think that's it for me.
All right. Very good. Thank you very much. Now, Dr. Acevedo Magarbel. Sorry if I butchered that.
And I'm speaking for both myself and Dr. Piggy. Dr. Piggy got such a presentation. We worked late on Tuesday. So we applied to providers for the vaccine very early on, and we got accepted very early on. And so the problem became, as soon as it became released, it was going to be that we were going to be able to order some vaccines, and we have to order, I think, 200 at a time. They said that we were going to be put on a website that would allow anybody in the community to come to our tiny little office and ask to be vaccinated. And at the time, it was when, lots of people were wanting to get vaccinated. They kept trying to enroll to get vaccinated. And the thought of our entire community lining up at our door to get the vaccine was a little bit daunting. And so we kind of just held off a little bit, because we're more than happy to provide vaccines to our patients. We're fit to do that with our staff and do it on a daily basis, and even make appointments to find that as many of our patients vaccinated as we possibly can. And if possible, to give it to someone else in their family who may not be our patient yet, but would become our patient. And reporting also a little bit daunting as well. But it was mainly the fear of getting put on a website that said anybody can come here and get vaccinated, and you can get a vaccine from nothing, you don't know them. So that was a little bit hard for us. We have a practice and the patient-physician relationship. We have a patient-physician relationship when we give somebody a vaccine who we've never seen in our office. Now we've established this, and now they can call us anytime. So, those were our concerns too. We don't have any history really. And so we were just apprehensive about that. We just wanted to be able to order vaccines. And like Dr. Richardson said, a single dose vial would be amazing. And we can still use those, and that would be amazing to be able to continue the vaccination effort. The 10-dose vial at this point might be difficult to use on yourself in the time frame that we're given. Now, at the beginning, when I couldn't order any vaccine, I probably could have gotten rid of 2 or 3 or 4 vials a day. But now it's much slower. And so that's our biggest concern. And in our experience with VFC in the past has not been a good experience. Especially when things expire and they're going to expire, and it was just fearful to order it. And that's pretty much what I have to say.
Okay. Now, I didn't quite catch your opening, so is Dr. Kagi going to speak as well, or just you?
Dr.
I'm sorry? Okay, then I still can hear. We'll move on then to Dr. Meyer Bennett, who's from Lakeside.
Hi, I'm Vera Bennett. I am in a very small town up in the mountains with, and it's a very small practice. I'm a lone pediatrician in a single pediatric group. We just added in the last year an adult nurse practitioner or family nurse practitioner, and then another pediatric nurse practitioner recently. But with the small size of our office, there's been a lot of challenges, and also with the distances involved in a really rural community. We started vaccinating as soon as we were able. So I want to say I got my first vaccine end of December, maybe it was. It was right away. As soon as we could get stuff, we started vaccinating the adults, and we were overwhelmed being a small practice with the amount of staff time it took to get everything in. And because we had to do it through our EMR to do any billing. I agree with Dr. Ravi is that initially we were supposed to be getting $16 an hour, and the diminishing returns when you have to rebill and rebill and rebill because we were getting a lot of denials for various reasons. Some of it was the way we were having to do it through our EMR and things like that, but it just wasn't something we were used to. As a pediatrician, I'm a vaccine advocate. So, for me, it's, get an arm in there and we'll get you vaccinated. But we definitely were overwhelmed with how much of the staff time it took. And we got really next to no reimbursement for that. So there were a lot of issues initially, and with that tiny reimbursement that we were supposed to get, it would be really nice if they decided, oh, we're going to make it 40, so let's make it retroactive, so at least there's something to go after. But that's horrible. We do not have the storage capacity to get the Pfizer vaccine unless they start telling us that the Pfizer vaccine does not need to be at those ridiculously low levels. I don't have the money as a single practitioner to buy a new fangled refrigerator that goes down to those levels. So all we've had available is the Moderna and the Johnson & Johnson. And initially we were just slammed with adults wanting to get it. And now it's a trickle. We can't even beg people to come in and get the vaccine. So I have been filling out that darn survey every day that I can remember. And I'll tell you, I forget on the weekends. If I'm busy and I'm not near a computer, I've got a life too. I don't need to be near my computer 24/7, 365. And to have to do that on a weekend, I've set an alarm on my phone. It's become a whole thing to put in that I still have 750 Moderna doses and 100 Janssen doses. And honestly, that number's not changing because nobody wants to come in. We've gotten the adults that want to come in and get it because there's been other things available up here. Our Native American population, of which I have a very large population, they all got it on the res. They had that availability. So if it was something along the lines of any other single vaccine that we have, it would be, oh, you want to get vaccinated? Here you go. We have that, but having a multi-dose vial that's got a shelf life of 6 hours, that's just beyond ridiculous because nobody can do that. Nobody can, if I'm going to start saying, well, let me open a vial for you. Now I got to look at my schedule and see who else is coming in, because honestly, our call system, we have nobody else we can call in. And even when we have people that need to come in for the vaccine, my staff tells me things like, well, we have 6 people for 10 doses. So now we're going to end up wasting it. And I know we've been told that we got to get them vaccinated and wastage is okay. But like other people have said, that's a little scary after having dealt with VFC and being threatened with being docked for stuff, especially since we get patients that no show. So that multi-dose vial, if it was a multi-dose vial like the flu, where it was good for 30 days, that would be one thing. But when it's good for hours, that's been totally it's a non-starter. And again, with Pfizer being the only one that's approved, if you tell me Moderna's approved, I will be out there vaccinating every single kid that walks in the door, because I have 750 doses of Moderna. Just not that many people are interested anymore. It's really mostly what everybody else is saying. We're struggling to get paid. The payment that we're getting is so not covering the cost of what it's costing me in staff time. So I have actually paid for the privilege of giving this vaccine, because I've had to pay staff. I've had to have it in my refrigerator. We've had to do all of the things that go along with giving this vaccine that I've had to pay for. So just because we get the vaccine for free, it's like any other vaccine. There is, even if we're getting them from VFC, they're not free. We're still paying for the injections. We're paying for staff time. We're paying for all of the management that goes along with proper reporting. We have never had an issue vaccinating adults when they come in. So, little Johnny comes in with his grandma, we're gonna get grandma vaccinated for the flu. But it's the same as we've said with everything else. The multi-dose vials just don't lend itself to that kind of system the way the flu is. So I think those have been our issues. We're certainly glad that we've gotten a lot of people vaccinated up here, and we're glad that we got to be a part of that. But it's been overwhelming for us. And now I'm just sitting there storing these vaccines that nobody wants sitting in my fridge. So.
Okay, that was very good. Very good. Thank you very much. Very clear. Okay, our last panelist is going to be Patty Gast, who is an MPH status in TAPI, and she runs their billing program. Go ahead, Patty.
All right. Hi. Thank you. I work in the TAPI billing program, which functions as a centralized business office for a majority of local health departments in Arizona and their billing activities. And we hold the insurance reimbursement contracts on behalf of the health departments, and we submit and work the insurance claims on their behalf. So we expected that insurance reimbursement, was supposed to come pretty readily for both contracted and out-of-network providers, but that hasn't completely been our experience, and it mirrors a lot of what Dr. Lefkowitz, Dr. Bennett, and Dr. Ravi have shared about their billing experiences. From our perspective, there is some good news in the sense that there are a lot of plans that are reimbursing us at the approximately $40 Medicare reimbursement rate, which is good. But at the same time, we're seeing a lot of short payments and denials from insurers. And this is all based on different policy and systems issues. We can especially echo Dr. Ravi's frustrations about Medicare billing for Medicare replacement plans, that patients aren't able to provide their, or not willing to provide their Medicare ID numbers. That creates a whole and very frustrating barrier. And if you can even get reimbursement, you might be able to get reimbursed through some different avenues. We also see that health plans are applying contract terms to the reimbursement for COVID immunizations. And that really surprised us, because we had thought it was going to be so much simpler to be able to get reimbursement, especially if you were contracted with a plan. And then our concern is, well, if they're applying our contract terms, what are they doing with out-of-network providers who don't have contract terms? Are they paying them in full, but yet they're discounting our reimbursements because of our special contract terms? And some of those pieces are things like some of our contracts with some of the insurance plans have mid-level provider discounts, like you get a discount if a nurse practitioner ordered the immunization as opposed to an MD. That could be anywhere from 5 to 20%. We have in some of our contracts mass immunizer or ancillary discounts. Again, that's about 5 to 20% that we could be seeing. We're also seeing that plans are applying timely filing. We thought that there was some federal guidance saying that you are, that timely filing has been extended for claims. So many of the plans have said, yes, that applies to CMS, but it doesn't apply to us. So we're worried with the large volume that the county health departments are billing for at this point in time that a lot of their claims are going to exceed timely filing limits and get denied just because of the massive coordination it takes to be able to get the encounter information together and get it ready for billing. And then some of the plans are providing provider credentialing or requiring provider credentialing because it's in your contract, yet we know out of network providers are supposed to be reimbursed. So we're fighting the plans on that, saying, there's a new provider at the county and we shouldn't have to go through the credentialing process. Well, that takes time and effort to contact the plan and educate them about that requirement. The other thing is that a lot of commercial plans are stating that we don't have to comply with CMS directives. So that includes, for example, they're discounting reimbursement for out-of-network providers, or sometimes the patient is actually paid directly, as we heard earlier in this discussion. And then we're seeing overall low reimbursement rates as well. We heard about UHC not increasing its rate and they're only paying $15. That is what we were still seeing to this day, even though we've been in touch with them for a couple of months saying you're underpaying. But we've also seen another plan in Arizona where they did have a 1 month long delay in reimbursing or increasing their fee to $40. And so there was a 1 month gap where they still paid the lower rate. And they said, we don't have to comply with CMS directives and we're not going to go back and reprocess those claims. So the other piece is that many plans are not compliant with the ACA. So there are grandfathered plans out there that we all have had experience with in the billing world. And of course, those are, deductibles, co-insurances, and co-payments are being applied in that situation. And we're also seeing that there are a lot of plans where immunizations are regularly not covered and they're not reimbursing for those. So those are the highlights of the negative pieces that we've seen. Some of the opportunities that we've seen is that HRSA has an uninsured program for billing for uninsured patients. We know that Access has managed care plans that must reimburse $40. Again, it's been taking a lot of work to get the $40 out of the plans, but technically, there are no discounts applicable or et cetera. And then most recently, HRSA has started a COVID assistance fund for the underinsured patients. When there's a patient out of pocket, when a claim is denied because immunizations aren't covered under that patient's plan, or when health plans make short payments. So those are great opportunities, but at the same time, these all require different system setups, and it's very challenging working with your EHR, as we heard earlier, and trying to follow through with the plans to help educate them on what they should be paying rather than what they are paying. And I just wanted to let you know that TAPI is approaching insurance companies on all of these issues. We have contracts with the major insurance companies in the state, and we're taking the payment issues to their top leadership in trying to benefit all providers statewide, along with the county health department.
Okay, that's good to hear. That's good, because that's an ongoing issue with vaccines for decades. So I'd like to thank all of our panelists and our presenters. This has been a rather full evening. Our time is up. However, they are going to leave the line open for comments for about 15 more minutes if people want to type in more comments. And Tappy again will look at all of these and record them, and then give some feedback where it's appropriate for them to do so. I'd like to again express my thanks to all of the panelists, all of the presenters, and to Tappy for putting this all together. Hope you all have a good evening and continue the good work. There's a lot of stuff that's going on okay, but it's become a real battle on the front lines especially. Thank you and good night.
Thank you very much. That was very informative.
Yeah, I think that was really interesting to hear everyone's perspective, and hopefully the federal government's hearing some of these suggestions too. I don't know if any work is being done on single dose vials. That would be fabulous.
Well, and unfortunately, they just went to 15 dose vials.
Oh,
so
no.
They're kind of going in the opposite direction.
I mean, that's fine for a situation where they have like a public health like tent and that kind of thing, but so many of our patients are not going to go to those places, and if their hope is to also do it in the community, they need to go both directions. So,
yes, definitely.
Okay. Have a good night, everybody.
Okay. Bye-bye.
Great. Thank you, everyone. And thank you, Dr. Richardson.
You're very welcome.
Thank you.